Okay, so welcome. So as Dr. Sevidanis was mentioning, I come from a pretty unique background and I employ all of my technological experience to how I customize my patients' outcomes using a digital fixed appliance. So I wanted to share a little bit more about that background so that you can see where this influence comes from. But I'll start by sharing that maybe like many of you, you're a child of an orthodontist. Pretty sure my dad's out there somewhere. Usually I see his light because he's filming, but I don't see it right now. So he's probably coming from another talk. So this is my dad, Dr. Bonebreak, the original in our family. And despite working in his office, in the summers and over the years, I actually actively fought against being an orthodontist. And I have a twin brother who had decided pretty early on in his career that he did want to be an orthodontist. So the pressure was off, and my brother was going through dental school and into residency. And my way of rebelling was to become a mechanical engineer. So I went to MIT, studied mechanical engineering, and this is where I learned how to work with my hands, how to appreciate science and the design and manufacturing process, and to be really analytical. And this is the approach that I take now with my digital treatment planning, which you'll see in just a bit. So after a few different things, I actually had a short career in finance. I did see the light and decided that Dad was probably right all along and I should have been an orthodontist. And it was actually at an AAO meeting all those years ago that I joined my family and realized that orthodontics is engineering. So this is my little coming back to AAO story. And so here we are. I attended the Harvard School of Dental Medicine for my dental degree, and then I went to UNC for my orthodontics. And what was really unique about UNC, among other things, is that the program director was also a mechanical engineer. So we put our heads together to think about what technologies are going to bring orthodontics into the future. We had aligners, we had self-ligation, there hadn't really been a lot of changes being made in different prescriptions for a little while. So we thought about, how can we use modern technology to really personalize fixed appliances the way that aligners are personalized. And so we did my master's thesis on 3D metal printing for orthodontics. And we studied the accuracy of the slots and the bond strength of the custom adhesive base that was built into the bracket. And we did this in service of helping to validate the use of 3D printing for orthodontics in some capacity. After graduation, we applied for a grant from the National Science Foundation to continue this research on optimizing post-processing protocols for 3D printed metal for the use of various orthodontic appliances. And so this is the experience that I had before getting involved in other types of digital fixed appliances, which is what I'll be sharing with you about. But to say that this is kind of my passion is really an understatement. This is something that I really am very excited and care a lot about. So my most recent practice experience has been with Mac Orthodontics in Hillsborough and Burlington, North Carolina. I'm adjunct faculty at the University of North Carolina, where I still teach once a month doing digital fixed appliances with all of the residents. I did join Lightforce as the head of clinical affairs, which is related to my financial disclosure. I am an employee and shareholder of Lightforce. But I also do my best to really try to serve our organization, our colleagues here, and I'm really honored to be on the board of the AAO Foundation and as a representative of NISO. So very happy to be here with all of you today. I have two acknowledgments that I want to share for this talk. The first is Dr. Alex Waldman. He is one of the earliest users of this particular technology, and because of that, there's just a myriad of cases that he has that really help me to teach specific teaching points. And so one of the cases that I show will be one that he started in his practice. And my other acknowledgement is one of the residents at UNC. This is Dr. Christine Bodie, and she helped to treat one of the patients that I'll also be presenting today that has some great teaching points. So thank you to Dr. Waldman and Dr. Bodie. So first, let's start by talking about what's in a prescription. The first straight wire prescription was by Dr. Andrews, as we know, 6 keys of occlusion. But what is this prescription based off of? It's based off of 120 untreated orthodontic models. These are averages, and they are averages based on the ideals of what made these teeth look nice. So over time, additional prescriptions evolved, and these prescriptions were trying to kind of compensate for some of the deficiencies of the original straight wire prescription, simply based off of the fact that, for example, with MBT, we have mostly perhaps class 2 patients in some of our populations. The excess use of class 2 mechanics will cause the upper incisors to retrocline, hence a much larger incisor torque on the upper central incisors and the laterals. So each of these prescriptions has kind of a different flavor, right? So depending on your treatment philosophy or the mechanics that you like to use, there might be a prescription that suits those needs, but they're still averages, and some would call them one size fits all. I say one size fits none because now I work in a personalized space. But this is what you're applying to every patient that comes into your practice, regardless of where they're starting, regardless of what their treatment goals are, and regardless of what individual needs they might have, even just from tooth to tooth. The limitations that we have around these stock prescriptions that you just saw are based on the cost of developing different prescriptions. To make an injection mold is very expensive. There's no incentive for orthodontic companies to fabricate new prescriptions. It's also not financially smart for you as the doctor to have inventory of multiple prescriptions. Maybe you have a high torque or a low torque alternative to your prescription for a couple of teeth, but it just doesn't make sense for you to have all of this inventory. All of that changes when we think about 3D printing our patients' appliances, because it doesn't cost us any more to create a new STL file than it does for any patient. Whereas to create a new mold for a specific bracket for a specific prescription is just never going to happen. So what you see here on this screen, on the left, that's the digital treatment planning interface, where you are able to really fine-tune, do your digital detailing for the patient. So if you think about your aligner setups, you're able to really holistically put the teeth where you want them to be. Let's not even talk about aligner overcorrections. But you're not treating your aligner patients to a particular prescription. You're treating them to the ideal outcome for that patient. And that's what you can do now in a fixed appliance world. What you see in the middle there is the resulting prescription from the setup, and this is determined by reverse engineering the brackets in order to achieve this outcome using a straight wire. And this is the resultant torque, tip, and offset that you would need for each tooth in order to be able to put the teeth there using a straight wire. And these are not prescriptions that you'll have in your office. First of all, they may not even be commercially available, and even if they are, perhaps it's not the one that you have in your inventory. And like I said, we don't carry multiple inventories of different prescriptions. And so as a result, what you see on the far right, those are all individual brackets that are 3D printed. This is before they are post-processed, so before they are translucent. And every single one of those brackets is different. It's for a different tooth, it has a different base, it has a different slot, it has a different in-out. All of it is different, and it doesn't cost us anything more to personalize these brackets. Now the process begins like most digital appliances that we use. It starts with a scan. You receive a digital treatment plan based off of the prescription that you submit. This digital treatment plan is set up by technicians at the company, and so what you receive back should be very close to your goals. And I'll be talking throughout this talk about how to communicate those goals. And then once you approve your plan, the brackets are 3D printed, as well as the indirect bonding trays. Because the perfect bracket only moves the tooth to the perfect place if it's put in the right spot. So the indirect bonding trays are also fabricated in order to transfer them to the teeth in the right spot. And then it's treatment as usual, because these are brackets and wires. We know how to use these. We know the treatment mechanics that are going to help us with our leveling and our bite correction, etc. In addition to the indirect bonding trays that are provided with the original case, you also receive a set of backup indirect bonding trays, or the individual jigs. And this is just so essential to the peace of mind and being able to always have the bracket in the right spot, because now if a bracket does debond mid-treatment, you can twist off the individual jig, and have confidence that it will always be rebonded into the right spot. So now I'd like to start by sharing some case examples, and we'll talk about how we can personalize these treatment plans from even when we start to submit the prescription in order to create a treatment environment that is going to be the most efficient. So we'll start with this young lady, and this is a patient that was treated, again, by Dr. Bodie here from the residency. And some of the treatment problems that we'll see were about a half-cuss class 2 canines, very upright upper and lower incisors, as you can see here from the Ceph. And in addition to that, let's treat to the incisor. Let's give her some really nice smile aesthetics. And that smile arc is a little wonky and it's a little inverted. So we are going to try to be planning here to improve the incisor torque while simultaneously maintaining our nice incisor display, evening out that smile arc, and of course, we have a lot of bite opening to do. So the first thing that we need to consider when we're submitting the prescription for this patient is what slot size we want to use. In your practice with your stock brackets, you don't ask yourself what slot size to use because you have a slot size in your drawer and that's it. But with a personalized appliance, you can select a slot size for each patient depending on their needs. The goal is that you want to fill the slot to express all of the prescription. And in my stock braces, I don't even want to fill the slot a lot of the time, because if I'm using a really high torque prescription and my patient doesn't need all of that torque, I'm going to stay in an undersized wire so that I don't inadvertently procline the incisors. But when you are digitally planning the case for each patient, now you want to express all of that prescription. So the goal is to fill the slot. For example, as well, if you have a simple crowding case and you want to just work on the alignment, but you don't necessarily want to have to work up through so many wires, you can choose an 018 slot for individual patients and just be able to fill the slot a little bit sooner. For my extraction cases, I like to use the bidimensional offerings, so I have better torque control in the anterior, better sliding in the posterior, etc. But my point is, you can customize the slot size and the combination of slot sizes for each patient. So for this patient that you see here, we chose 020. And then the second thing we can think about is where we want to place some hooks. And I think we just take for granted that our brackets have hooks. Sometimes we use them, sometimes we don't. But if you can personalize where you have hooks and you can start to anticipate what treatment mechanics you will be using during treatment, then we can make sure we have hooks wherever we need them. And so for this patient here, we chose them on the upper 3s and the lower 3s, 4s to facilitate some anterior triangles if needed during treatment. And of course, we can use the class 2 elastics as well. There's two types of hooks as well. There's a mesially directed hook for your traditional class 2 and class 3 patterns, as well as a bidirectional hook for a little bit more flexibility. And then the last thing that I'll touch on for customization is the placement of the bite turbos. And with traditional braces, I only ever really had 1 or 2 places I put the turbos. It was usually on a molar, sometimes a premolar. Why? Not for any treatment mechanical reason. It was just because it was convenient. It was easy. I could isolate it. It was easy to get them to be even. And it's hard to manually put turbos on the upper incisors, even if I knew it was going to help me with my treatment mechanics. The preformed turbos, if they're not put on evenly, you're only biting on one, you have a problem. You have to make that even for your patient. So with a personalized appliance, the bite turbos can be digitally planned to open up the bite just the right amount, and they can be placed on pretty much any tooth you want them to be. So it's helpful, to think about what your treatment goals are, what your problems are, and what mechanics you'll use. So for example, in the case that you'll see here, we chose the bite turbos on the upper incisors, and that was to help us with the leveling of the bite by providing an intrusive force to the lower incisors. If I have too much overjet, I'll place them on the upper canines. For a moderate bite, or for my adult patients, I'll place the turbos on the upper 4s or 5s. And for those open bite tendency patients, to make it easier to control the vertical, I'll place the turbos on the 6s or the 7s. And again, that used to be just my default placement because that was just all I ever did. I didn't have a good reason. It was a turbo of convenience, and I was working against myself with those deep bites. So as you'll see in this case, as we progress, those anterior turbos were really effective in helping us to open up that bite efficiently. So now that we've submitted the prescription, which is when we should first be starting to think about our treatment plan, our treatment goals, now it's time to really do our detailing. And as I said before, we have technicians that will set up those cases for you based on your treatment goals if you've communicated them. But you still have an opportunity to make those fine-tuning adjustments through the digital treatment planning software. So now that we're ready to detail, we need to think about our mechanics, and do we need to do some overcorrection? And I'm going to start here by talking about torque. So when it comes to overcorrection, I want you to think about it with a fixed appliance much differently than you would with an aligner. With an aligner, you're adding overcorrections to try to create force systems to do things that are just kind of hard to do with plastic. If you have a deep bite, you're finishing with a much larger open bite than you actually hope to achieve, as one example. When it comes to the overcorrections that I like to employ for a digital fixed appliance, it really comes down to physics, essentially. So the first thing I'll think about, remember we talked about the wire slot play. I know how much wire slot play that I'll have, predictably, because the 3D printed brackets are very parallel and they're very accurate. But I also need to think about these factors that are going to just make it more difficult mechanically to improve my torque. So for example, if I'm starting off with really severe incisor retroclination, torque just takes a long time. I've got to move that root all the way through the bone. So I want to add a little bit of overcorrection, not because I want to actually overcorrect the torque, but just because I want to start those teeth moving in the right direction from day one, or as soon as I put in an edgewise wire, and not have to wait as long for that torque to express. The second factor for a patient like the one shown here, and our patient, is class 2 mechanics. We're pulling on either the canine or maybe on a post that's attached to the wire, and we are kind of actively keeping those upper incisors back. Another factor is maxillary space. As we know, when we're closing space, especially on a slightly undersized wire, we're going to be rolling those incisors back around the wire and losing torque in that way. And then lastly, we need to consider what our final wire size will be compared to the slot. So I use the 020 slot most often, and therefore my finishing wire is a 1925 NiTi. If I was using the 022 slot option and finishing in a 1925, I would be overcorrecting much more because that's 11 degrees of wire slot play instead of 5. And so when it comes to how much to overcorrect, the first thing I mentioned is we just have to take care of the mechanical wire slot play that we have, just given the nature that we have some clearance around the wire. The largest wire I'll get into an 020 is a 1925. So I may have between 4 and 5 degrees of slot play. So right off the bat, I will be overcorrecting just that 4 to 5 degrees. But if I have those additional factors that are going to make it difficult to express the torque in the upper incisor, I will be adding an additional 4 to 5 degrees. So what that ends up looking like, this is where we are starting for this example. This may be what I want to express. This would be ideal as a finish, but the digital treatment plan that I accept is going to look more like this. Not because I expect to finish there, but because by building in that extra torque, it's going to get me moving in the right direction a little bit sooner, and it's going to counteract the wire slot play and then any of the additional biomechanical factors that are going to make it more difficult to improve the incisor torque. So for the patient that I showed you earlier, this is the digital treatment plan, the initial and then the final. And I can use the tooth movement table to confirm how much additional crown torque I've put into the digital treatment plan for both the upper and for the lower, because we're starting with very upright upper and lower incisors. And I won't ask you to remember these numbers. I'll bring them up at the end, but we're going to compare how did the treatment reflect what was put into the plan. And so we're planning for around 30 degrees of facial crown torque in the plan. What we expect will be to achieve something a little bit less than that. For the lower as well, we're planning in around 10, 11 degrees of facial crown torque on the lower incisors. And because of class 2 mechanics, where we might actually be proclining the incisors, that's probably a more realistic result of what we will get. But note that while I am programming positive facial crown torque on the lower incisors, the resulting prescription is still negative, because I still want to have them slightly upright because of those class 2 mechanics. So the tooth movement table and the prescription table work together. It's all about where am I starting versus where am I going, but where do I want to be finished? This is the negative 3 degrees relative to the vertical plane versus the absolute movement. And as I hope you appreciate looking at this prescription table, this is not a prescription that I would have in my office. This doesn't exist out there. This is Dr. Jackson and Dr. Bodie's prescription for this patient. Within the digital treatment planning software, we're also able to really pay attention to that smile arc, to those aesthetics. We can move the teeth ourselves. We can extrude the incisors. We can then intrude the lower incisors to maintain the level of overbite. And then this can be immediately proved and sent to manufacturing without having to go back and forth with a technician. What's even better than doing an aligner setup, for example, is that I don't have to stage this. I'm not trying to decide where to put space before I can do certain movements. I'm not worried about staging the IPR or anything like that. I'm just worried about the final outcome. And then at the end of the day, what you see is what you get. This was immediately after bonding with Dr. Bodie, so it's just immediately translated to the patient with the indirect bonding. So I'm going to walk through some of the progress for this patient here. So initial bonding started 0-4 NiTi. One thing that I want to point out is that the upper left 3 was not engaged fully because it was higher on the left than the right. So we did an incisal tie on that tooth to bring it down gently. Therefore, at the next visit, about a month later, that's when we fully engaged the upper left canine. I also want to point out, if you're noticing that the molar tubes here are metal, that is because this case was started just before the custom molar tubes became available with this digital treatment planning system. So all cases now have custom 6s and 7s, but this was treated just before that. So now we're fully engaged. Remember, we have the anterior bite turbos, so we're already starting to see some leveling of the curve. And then by about another 5 weeks later, maybe 5 or 6, now we're ready to go into our second wire, which was an 18-18 NiTi. And what I really like about the 18-18 NiTi is that it's more flexible in the in-out dimension than, say, a 16-22 or a 14-25, which means that you can still engage it even if you have some slight rotations. You can still steel tie this wire in. And that gives you the advantage of starting to work on your torque a little bit sooner, which again helps us to be more efficient. You can also appreciate how much, again, this bite is leveling, the bite is opening, she's a growing patient, we're getting a little bit of posterior extrusion as well while that bite's open. And this is also when we began some class 2 elastics. We're in an edgewise wire, so we're going to limit, so we're going to limit the proclination. And because the posterior teeth are discluded, that does allow for a little bit more efficient bite correction as well with these early elastics. So by another few months later, we're nearly class 1 in our canine, but you will notice that there's a little bit of a reverse smile arc coming in. And that's because our bite has sufficiently opened, and now with those anterior bite turbos in place, it's starting to maybe intrude the upper incisors. So management of the turbos through treatment is important no matter what your clinical situation is. But at this point in time, we removed the upper turbos, and a few months later, everything was leveled, bite was corrected, and we were ready to scan for debond. So this is the patient's final. The treatment summary was 8 appointments and 14 months. And I'm actually kind of sad because Dr. Bodie and I finished most of our patients pretty early on in her residency, and she's just such a pleasure to treat with that now we just don't have any patients together. So this being one of them. So very nice work, very efficient treatment, great patient, of course, who cooperated with our instructions. And when we look at the final records, we're able to assess what those changes were. We wanted to improve the torque on the upper and lower incisors. You can see that we improved those. And when we go back and look at those original numbers, it really makes sense. We improved the upper incisor torque by 23 degrees, and what we had in the plan was around 29. And that's what we would expect given the wire slot play, given the class 2 mechanics, and given the level of retroclination that we began with. So it all makes sense. And those lower incisors moved forward pretty much exactly as predicted, about 11 degrees. Because even with the wire slot play, those class 2 elastics helped to push the teeth over the wire with that wire slot play. So I'm going to go quickly through the next case because I don't have too much time left. But I just want to share, again, some examples, let's say, for a class 2 camouflage case. So this patient's chief concern, protrusive upper and lower incisors. And he was already missing an upper right tooth, and he'd had a space maintainer in place. So the decision was made to do a class 2 camouflage by extracting the contralateral 5 and closing the space. So how can this treatment plan be optimized? Well, for a couple of things. When we're finishing class 2 molar, we want to add a little bit mesial molar in rotation on the upper sixes to reduce the buccal overjet when you're finishing in a class 2 molar. We don't have to place brackets more distally here to try to do that. We can just move the teeth in the digital treatment plan. Additionally, we're starting with some, since we have a lot of space and we'd really just like to retract the upper incisors, we can add a little bit of overcorrection to those upper incisors so that we don't just dump them back. We can also upright the lower incisors to offset the use of the class 2 elastics, and we can converge the roots, the upper 4s and upper 6s, adjacent to the extraction space. So this is the patient with 8 months progress, and spaces are closed. We've minimized the buccal overjet at the upper 6s. We're just waiting on a little bit more of the leveling to occur, especially in those upper molars. But then it doesn't seem like there's going to be a lot of detailing to do in this case because we've digitally detailed ahead of time. So again, initial and then progress. But we've been able to improve and somewhat maintain the upper incisor torque, even though we've retracted it, reduced the proclination, because we built that into our digital treatment plan. And then lastly, I just want to share a couple notes about using functional appliances for class 2 correction. The first, if you'd like to use Carrier, unfortunately at this time you cannot digitally remove the appliance from the scan because then a custom base would not be able to be fabricated. So it is recommended to remove the appliance following your bite correction, scan then for your personalized braces. Best practice would be to maintain with an Essex retainer until bracket delivery to ensure that the indirect bonding trays fit. But the benefit of doing that is that you can do some cutouts and buttons and have them continue to wear elastics with the aligners or with the Essex while you're waiting for your indirect bonding trays to arrive. And then lastly, if you're using a bonded functional appliance, such as a HERPS for class 2 correction or maybe even an RPE, I recommend that you plan all of the teeth at the beginning, include the details of your functional appliance in the prescription because then you can receive individual bonding jigs for those posterior teeth that you can use later after you've used the appliance. If you're using something like a HERPS or a fixed functional class 2 corrector, you can upright the mandibular incisors a little bit more. And then I recommend that you bond and use the functional appliance as desired. You can use your custom braces for the rest of the teeth. And when you're finished, you remove the appliance, bond the posterior teeth with those individual bonding jigs because you've already planned them. You already know where you want them to go. So very lastly, as I am out of time, it's the summary, so it's perfect timing. So very quickly, when it comes to torque, overcorrect depending on your slot size and your final wire size. And remember that the goal is to fill the slot. If you're anticipating class 2 mechanics, you can digitally upright the lower incisors. Utilize those anterior bite turbos for efficient bite opening, but remember to monitor them. Using early elastics while the teeth are discluded for efficient bite correction. This is case specific. Case selection is important, but I find this to be very helpful in improving the efficiencies of our cases. And then remember, if you have a class 2 camouflage case, you want to tuck those molars mesial in, which is much easier to do with a digital appliance than with a wire bend. And lastly, if you're using a functional appliance, plan all of your teeth at the beginning, and then use those individual bonding jigs after you remove the appliance for maximum efficiency. So thank you so much for listening to some concepts of digital treatment planning. I'm happy to answer any questions, and I hope you learned something new.
Thank you so very much, Dr. Bonebreak Jackson, for the very thought-provoking presentation. Do we have questions for Dr. Jackson? I do have a question from your actually take-home message, as hopefully we are getting ready to go and get some rest before the receptions. In your recommendation to digitally upright the incisors, and we had a lot of discussion in this class 2 correction session on do we want to upright the incisors. How does Lightforce plan for keeping the roots inside of the bone? Because it's easy to think about uprighting the crowns, but where do the roots go? Do we have the bone for the roots to be upright?
Yes, and that's a very great point. And the purpose of digitally uprighting the teeth in the digital treatment plan is not to actually achieve that level of uprighting, but to limit the amount of proclination that will happen. So it's all about taking into account what the wire slot play is and what the mechanics will be, so that you're not trying to finish here, you want to finish here, but you plan it to here because of that mechanical wire slot play that you have. The second part of that answer would be that it really does depend on your diagnosis and treatment plan. So us as the practitioners, as the diagnosticians, it is important for us to make sure that we are using mechanics that are appropriate for the patient and making sure that we're diagnosing that properly.
And do you have tips for us as clinicians of how do we plan how much overcorrection? How do we learn which cases we need to overcorrect in terms of understanding the technology that is made available?
Yes, so what I've shared today is really a combination of the things that we have already learned. And we've been, evaluating the finishes, and we've been, scanning them and superimposing them. So what you've seen today really is a summary of what we've learned as a best practice. The exact amount of overcorrection, it's still going to be variable because our patients respond differently. So there is still some machine learning that we have to do as the practitioners when we're evaluating our patients' progress. But what we have seen consistently is that these types of overcorrections that were mentioned today really do improve the efficiency and lead to an ideal outcome for those reasons.
Okay. Ask the last question now or remain silent. Okay, so thank you so very much. Thank you, Dr. Jackson. Thank you so much.